if you've entered the room, why don't you go ahead and chat your name and where you're from in the chat box so we know that people are here. Appreciate it. All right, well, I'm going to get started. Welcome. Thank you for joining us this morning. I'm Tammy Alexander, the Vice President of State Relations at the School-Based Health Alliance, and I'm your monitor for today's session. I'm joined by Carlos Romero, the founder of Apex. Apex is an evaluation studio based in Albuquerque, New Mexico. Apex has been serving the public and nonprofit sectors for over 2 decades, providing program planning, evaluation, facilitation, and technical assistance, including technology and data collection and reporting. Apex works with a wide range of organizations and programs that address educational, health, social, economic, and racial inequities. Carlos is a leader in the field of evaluation, including the equitable evaluation movement. Carlos is also a leader in the school-based health center field, in part because of a data system Apex created to support more effective implementation and evaluation of SBHCs. The Data Hub is used by SBHC networks across the country, and there's growing interest. Apex collaborates with us, School-Based Health Alliance, and many state affiliates to scale and sustain a data solution that will support school-based health centers at the local, the state, and the national levels. During today's session, Carlos will give you an overview and what's new with the School-Based Health Center Data Hub, which features individual, clinic level, sponsor level, and state level reports. And very importantly, it's aligned with SBHA's Census and National Quality Initiative. Carlos, I'm going to get your slides up and turn it over to you.
Excellent. Thank you, Tammy. And thank you all for putting your names on the list. I see some familiar faces, some friends in some of the states we work with, and other states we're getting ready to work with, including some New Mexico folk. So my name is Carlos Romero. We're based here in Albuquerque, but we're working with school-based health centers across the country. And I appreciate SBHA making the space for this type of a session. My plan for today is just to talk to you about what the Data Hub is, how it works, and show off some examples, give you some free samples of some data visualizations. And all the reports I'll show you, I'll be able to give you in the end using a QR code. So stay tuned for that. But I wanted to start off talking to you a little bit about my school-based health center journey. I was in a conference, a community schools conference a few weeks ago in Los Angeles, and there was over 3,000 people. It was the first in-person conference that they've had since before the pandemic. And a lot of people were saying, oh, it's like a family reunion, and I was very jealous because I'm not really part of that community yet as much as I am this one. So I definitely appreciate the virtual nature of bringing together, but I can't wait till we can all be physically together and eat and drink together like we used to do. But it also reminded me of how I fell in love with school-based health centers in the first place, which was also in Los Angeles, one of the very first SBHA conferences. And I'm wondering if there's anyone out there who was there. It was in 1996, 97, Tammy and I were thinking, but it was one of the first ones. And it was one of my first professional conferences. I was a young research associate at New Mexico Highlands University before Apex came to being. And I was there, and I really was there to support someone else that was doing an evaluation presentation. So she said, basically, go to any session you want. And so I remember looking at the agenda and seeing that, oh, school-based health centers are built to help families like mine that did not have access to healthcare, that had a variety of issues. I went down and thought, oh, I could have benefited from this and this and that. And so that was my love affair with school-based health centers. I also remember that trip because I got in trouble for upgrading to a convertible. For $10 more a day, I was still at the university, and that apparently was frowned upon. So that's sort of the personal, I think school-based health centers for me are a personal issue. But professionally, we've been working with school-based health centers since before 2007, but really 2007 is when we started doing statewide evaluation of school-based health centers in New Mexico. And I'll say a little bit more about that professional journey. But the Data Hub is essentially an ecosystem for evaluating school-based health centers. I think it also includes some tools that help run school-based health centers. And so here's how I think about the Data Hub. It's about those different purposes of evaluation, whether it's accountability, advocacy, which is a lot of our partnership with the Alliance and the state affiliates. My favorite is learning. What can we learn from data? How can that inform policy? And it's built to appeal to the different audiences for evaluation, whether that's the clinical staff doing the work on the ground, administration staff of the sponsor agencies, schools, funders, advocates, state level. And when we built the data hub, and it's an ongoing work, right? It's an evolution. But we think about these features and benefits as we want things to be as efficient as we can. So we collect data at its source. We like granular data. We're not shy about collecting data. And we like patient level, visit level, code level data. And you'll see the reasons why. We think the data should be timely in the way that we bring it back to people. We strive, of course, for accuracy. We want the right people to have access to the data. We want consistent data. And most importantly, I believe in the saying that context gives meaning to data. Data without context is meaningless. And so we really want to know what is the context to help us make better sense of the data. And anytime we can add value to the work, we strive to do that. So that's a little bit of the DNA underneath the data hub, the thinking that goes behind it. So we started in New Mexico in 2007 with state funding for school-based health centers. It was a big expansion. Our current governor, Lujan Grisham, was then Secretary of Health, and she was part of a big expansion. We have about 54 school-based health centers in New Mexico that are state funded. There's maybe 10 others that are not. And then we have Indian Health Services. So as a state, we have about 80 school-based health centers. Now we're evaluating just the state funded ones. But for our size, that's a pretty big network. And when we came on the scene, our job was to evaluate. And the main evaluation instrument was a monthly level of operations report. And people would fill in just how many patients and what types of services, and they would submit aggregate data. And I found that unsatisfying because it really locked us in, and we couldn't really do much with that data. And I had a lot more questions than the data could answer. So I started asking the question, well, where does this data come from? What are sites using to collect this data? And at the time, this is before electronic health records. Some had patient management systems, maybe 10 of the 40 at the time. And the others needed something to collect. And I'm getting a little ahead of myself around the use cases. But that was the first version of the data hub, was giving people an electronic health record. At the time, it was a patient management system called Welligent. And everyone started using that to collect their data. And those that weren't, we created a little data warehouse process. So now we had all the data in one place, every patient and their demographics, every visit and their code. And that was version 1. Then a few years later, we started working in Colorado, a joint project with New Mexico Department of Medicaid, Colorado Department of Medicaid. And it was a demonstration grant, a CMS demonstration grant, to prove how school-based health centers could be part of the medical home model. And so that is where Just Health was born, and we'll talk a little bit about that later. And then a few years ago in 2018, we met Sarah Murphy, if you're out there, or someone from New York. Sarah Murphy was the director of the New York affiliate. We met at the Long Beach conference. And then over the next few years, we did a needs assessment and evaluability study. And now we're piloting the data hub in New York through their alliance. Last year, we started a partnership with the Massachusetts Public Health Department to bring the data hub to their network of school-based health centers. And then just this year, we're starting to work with Delaware and their state affiliate. And the story is every state has looked different. So a lot of times people will ask, how do we get started? Sometimes there's public health funding, sometimes the alliance, sometimes a grant. Delaware is an example of a health and human services grant for interoperability. And we're sort of using school-based health centers as the context to demonstrate how we can pull data across different systems, different sources, and make it useful for that school-based health center community. And so we can come back and talk about the different states and the context, and there'll be plenty of time for questions. But I want to spend a little bit of time talking about what makes the data hub work. And I call them use cases, and you'll see what I mean. But really, the data hub is just about 4 use cases: bringing in those existing data sources, collecting new information whenever it's needed, linking those things together, and then reporting. So 4 simple, universal, adaptable use cases, but then again, they look different in different contexts in different ways. But let's walk through each of them. Existing data sources is where we're pulling from electronic health records. That's the biggest source by volume, and we interface with all of these electronic health records. If you don't recognize yours on this list, we've never found one that we can't interface with because of the interoperability standards that are in place. And so that's the first piece of the data hub. Again, granular data, patient level, visit level, code level. We also interface with the Colorado Immunization Database as another example of bringing in existing data. That's really less for evaluation than it is a value add that I mentioned earlier. It's just to make it easier to put that data at the fingertips of the school-based health center people in the field. We get lots of questions about interfacing with the health information exchanges. That's actually one of the things we're working on in that Delaware project with the Delaware Health Information Exchange, and interfacing with student information systems. We're piloting this at the state level in New Mexico. So the big idea though is if the data is already there and it's in digital format, how do we bring it in to the data hub in a way that we can, that's useful for us? So the second piece of the second use case is collecting new information, data that's not readily available in digital format. And this is, there's a few different examples. The biggest example and the second biggest volume of data in the data hub is Just Health. And Just Health was born in that project in Colorado where I had the same question, right? We were saying, how do people screen? And there was it was called the Student Health Questionnaire. And it was this long, 5 or 6 pages. And I had the same question, where does that data go? And it went into a paper chart. And we couldn't ask or answer any questions about that. So with some of those grant funds, we digitized and the electronic student health questionnaire was born. Later, we got a CDC grant for 5 years that sort of branded it and made it into what is now Just Health. But it really is just a framework. It's based on the principles of comprehensive universal screening. It includes those evidence-based validated tools like PHQ-9 and GAD-7. But the point is that there was no way to collect that data, so we created a tool that is now being used by most school-based health centers in New Mexico and Colorado. And we can talk a little bit more about what makes Just Health work. The second example of collecting new information is what we call the operational plan. And this is just a set of forms, but it collects information about staffing, hours of operation, host school demographics, funding sources, quality improvement priorities, and success stories. We'll talk a little bit about some of the success stories that come. This is how we align to the SBHA census. This gives us a lot of those contextual things that we can use to cross-tabulate, and you'll see some examples of that in the reports. And then the last piece of new information is what we call the patient feedback survey. There's also a parent one in Colorado, but this is anonymous feedback that includes satisfaction, but it goes beyond that. It gets at some health literacy, positive youth development, on the patient perspective on their own academic outcomes and health outcomes. And this is anonymous, so it's linked to a site, not to an individual. So that's the second use case. We can circle back if there's questions about Just Health. We've kind of gone through a whole repurposing and replatforming so that it's now cross-platform. It was an iOS-only app for the first few years, and so Just Health, we like to think of it as a bridge to a conversation, right? And we'll end with sort of an example of how Just Health really says a lot about the thinking behind the data hub around collecting granular data, making it useful for as many people as possible, as quickly as possible. And really, it's all part of that idea of comprehensive universal screening. I think that's within the DNA of school-based health centers. And this will be available to you in the slide deck if we want to say more. So those are the first 2 use cases: existing data, collecting new data, and then we work to link them together and report. And so now I'm going to walk you through those free samples I was telling you about, starting with the Snapshot Report. And I'm not expecting you to be able to read everything, on the screen, but the Snapshot Report is kind of the flagship table-based report that we produce. And this sort of summarizes a lot of the utilization data that you see. It gives a comparison so you can see where a site compares to a sponsor, to a state. And so those comparisons are useful. It's aligned to the performance measures, so you can see where you are at compared to where others are at. There's a version of this that's multi-year, so you can see your change over time. But that's sort of the one output you get is the data snapshot. And we use this for quality assurance, and that leads to some quality improvement around coding, around other things. So the data snapshot is a really important product of the Data Hub. But usually what gets people more excited are the formatted reports. And again, I'll make these available to you, but I wanted to show you a few things that come from the New Mexico report. And thanks to New Mexico Department of Health, Kristen Oreskovich and the whole team are always very generous at letting us share these reports. And so both of these reports will be available, but I wanted to highlight just a few things to make the point of what the Data Hub can do. So first, just the basic descriptives, right? Here's New Mexico, and we can show you where the school-based health centers are in relation to healthcare shortages. We're a desert in more ways than one, including healthcare desert, but you can see where school-based health centers are placed in relation to those needs. Then there's those basic utilization. How many patients, how many visits? What's the overlap between primary care, behavioral health, and dental? What's the average number of visits by the type of care that they receive? So again, some high-level descriptives that can really paint the picture of what school-based health centers look like. And then we can start diving down deeper. There's a page for each of these. So here's what primary care looks like. And I wanted to zoom in just as an example of showing we can break down the types of care at a visit level based on rolling up codes. So this is different types of primary care, for example. And I feel like I'm talking right into the abyss. I wish I could see you all, but I know someone's monitoring the questions, and we'll have plenty of time for questions. Here's a data view and a data visualization around behavioral health. And I wanted to zoom in on this one too, because I think it makes the point of context and data and cross-tabulation and disaggregation. So what we found based on just health data is 36% of all school-based health center patients reported some depression or anxiety symptoms, some mental health concern. And they say that, the averages hide the story, that the stories are in the spreads. And this is an example of that, right? So that 36% should definitely get our attention. But when we look at what that looks like, when we disaggregate by social determinants of health, right? So how often does that co-occur with some level problem at home, problems at school, food insecurity? What about other health behaviors, whether it's substance use? I think this one's mostly substance use. And then those personal identity factors. So this is an example of really looking at that data and informing those conversations about health promotion, population management, your relationship with your school stakeholders. So I also wanted to highlight a page around how school-based health centers have responded to COVID in New Mexico, and in particular, pull out this chart. So this is sort of a time series of looking at what utilization looked like over the 2019-20 school year. And the one thing I want to note is that we started producing this data visualization in March and April, right? Because we already had the data, because we were collecting code level data. We were never asked to sort of say, tell us about telehealth. And you can see if you zoom in, there's a tiny little thread, so telehealth's always kind of been there. But then when stay-at-home orders came and the pandemic hit us hard, we saw school-based health centers pivot, and we saw them stay open, first of all, an impressive feat of itself. And then school-based health center telemedicine came on. And I also wanted to show you, this is not in the report, but this is another visualization where we continue to look at that through this next school year around what does it look like once it reopened. And you'll see, there's still that struggle. The reopening is still a work in progress, but telehealth has now become a bigger part and a consistent part of that set of services for school-based health centers. So again, a demonstration of what the Data Hub can do when we collect that granular data. It gives us a lot of flexibility to answer questions we didn't even know we had, we didn't know we would have. So I want to show you one last data visualization. This doesn't show up in a report, but again, it demonstrates the power of the Data Hub. And this is relating to the performance measures, right? Comprehensive well exam, BMI assessment, depression screening. So we can calculate those and roll them up from codes and say, here's where New Mexico stands, and we can have confidence in that because we know it's coming from visit data. So we can also look at that. Again, remember, averages hide the story. The story's in the spread. So if we look at it by sponsor, we can see, yeah, our state average is 74%. Where's each sponsor along that? And some are doing better and some are below that. And then we can go even one step further and say, within each sponsor, can we look at site level data and see where they are? And again, this can inform quality improvement conversations, and it has when we can break down data by this level. And so the last thing I want to say in the last visualization is, this is a screenshot of what we call the alert report. This is what the provider gets right after Just Health. And there's more to it. You can scroll down, but this is sort of the first screen of getting in a snapshot just a sense of what's going on with this patient, right? It scores the things that are scorable. Those little donuts are sort of each health domain. It shows you where there's protective factors and risk factors and things that need attention. And when we set out to do the Data Hub, I never thought that it would be an important clinical tool. But what we found is our first stakeholder, the first people that need the data, are those providers themselves. And if we could find a way to give it to them and inform a better conversation. And there's a lot of talk of health equity, and I think this is an example and a good conclusion around how the Data Hub can support health equity, because it's not like other systems, YRBS or surveys. I saw a research report on a survey about the level of mental health, and I thought, well, what happened to those kids? Do we know what happened to them? Do we even know who they are? And the beauty of the Data Hub, I think, is that we can drill all the way down, and we can have some assurance that whatever the needs are, that person got service at a school-based health center. And again, for me personally, every time I see Just Health leading to a conversation that might not have happened, whether it was about anxiety, which I experienced, or sexual identity and orientation, I think now the Data Hub's working and it's promoting health equity because of the way we collect data. So let's revisit as we wrap up. Let's talk about that data ecosystem. So now we go and say, what are the purposes? What are the audiences? What do we want that to look like functionally? But now I want to sort of conclude and wrap it around another way to think of the data ecosystem is, do we really understand the opportunity for service? Do we understand what those needs and conditions are of the populations that we're serving? How well are we responding to those needs? And is it making a difference? Is anyone better off? And so that's the other frame that we look at the Data Hub is, can we answer all those questions? Can we build an ecosystem that is aligned to those principles of school-based health centers, prevention, early intervention, the integrated model of care, striving for equitable access? And can we find out and ask and answer questions about those outcomes, utilization, improved health outcomes, educational outcomes, social outcomes? So that's the Data Hub. We definitely have plenty of time for questions since I talk so fast and since I can't really see anyone, so I just keep going faster. But if you leave that last one, that QR code will take you to the reports. I'm sure I can send them to Tammy later, but I'm also enjoying the resurrection of the QR code. When it first came out, I was like, well, it's like Google Glass, right? What good is that going to be? And now we can't go to restaurants without it. So thank you for your time and attention. I look to Tammy and Jenny to tell me if there are questions. And
we do not have questions yet, Carlos. And so this is a different kind of platform. So please enter your questions into the chat, and Carlos can see them. I can see them. Jenny can see them. I appreciate, Carlos, you giving a historic arc to where this came from. And so often ideas come from passion. And so I really appreciate you sharing that story and sharing what states are doing this work. And there's growing interest as I talk to states, and they're starting to set up, say, their state program office at the state health department or the Department of Education. I'm always encouraging them to make sure they think about data. Data tells so many stories, so I just appreciate you knowing that. Okay, so we have a question. Is this being used in other states than New Mexico? It's from Mia.
Yes, thanks. Good question. Yeah, so in addition to the states that were listed on the PowerPoint, so New Mexico, Colorado, New York, uh, Massachusetts, and Delaware, that's in chronological order. And we have a few other states that are on deck, and then a few other states that are sort of asking questions. So there's a pipeline of states that we're working with. And the goal is, and this, I'm glad you asked the question, because I think we're also working with other evaluators, right? So this isn't about Apex evaluating every state. This is about providing a tool that's consistent for every state. So I think in the case of Massachusetts, we're working with their public health department and their evaluators. A few of the other states also have evaluation capacity. So it's almost kind of a business to business model, if you will, that we're the evaluation consultants, but we're also licensing the data hub for other evaluators to use.
Great. And then Barbara's asking, what is the ability to access and the cost?
Yes, always the question, right? So, and right now we're working at state levels, whether it's with public health or the Alliance. So the data hub is really not built, at least in its current form, for a single school-based health center or a single sponsor. It really starts to work once we have multiple sponsors. So, and then the costs are also vary. In some states, there is state funding, and that state funding includes an amount for evaluation, and we've competed and won those contracts. And other times we go after, in New York, we're looking at philanthropic fundraising to support it. In Delaware, it was that big federal grant that we got for human services interoperability. So far, all the funding has kind of been above the sponsor. Like, we've never asked sponsors or school-based health centers to pay for the data hub. There's usually some other concern, whether it's the Alliance or a public health entity. So I see Jessica's question. Also a good question. There's a few different options, right? That we are adopting some tools that allow for actual interface, application program interface. But I think still the most popular model is we've created a data flow, which is extract, transform, load in tech terms. And that means we work with your EHR to see how do we produce that data set, right? Every patient, it's a very simple data set, patient demographics, visit, date, and codes. And then we create a secure FTP transfer where that gets transmitted to us and ingested into the system. And we do that on a monthly basis. And some have automated it. So that is the question on EHR integration. Oh, thanks, Roxanne, for the comment. And Karen, also a friend in Colorado. Yes, it's sort of coming soon. And Karen, you probably had some of the coming soons in our experience together over the years. But we are working to automate the data snapshot, and that's on deck for 2023. I'm pushing the team. But yes, some of those data, the data snapshot will be something you can access in whenever you need it. And also some of those visualizations that are showing up in the formatted report will be part of some dashboards. So I'll take that last question on Epic. Yes, you send us that data file, right? It's an export of, every patient is a row, every column is one of those data fields, and then we ingest it and take it from there. And that's what produces the snapshot. That's what produces all the visualizations. And the question about startup school-based health centers is an interesting one, because we're doing some work in the community school world, which I think is sort of the school-based health centers are part of the community school model. And we built a return on investment. We did a return on investment study that showed the value of a community school coordinator, and now that's being used to make the case for other school-based health centers to invest in the community school coordinator, knowing that they will pay for themselves. So I feel like this could be similar, is that if you look at those New Mexico reports, that's usually what sells it to another state around saying, this is why school-based health centers are important. This is why evaluation of school-based health centers are important. So that's sort of the answer of, the data to make the case for your school-based health centers, I think, is there. And there's probably there's plenty of other research too, but. let's see. So where, oh, I'm forgetting to scroll down.
Jenny's taking care of it for you.
Okay. Yeah, we'd love to be in Michigan. We'd love to be in every state, and I think we're pacing ourselves right now. The mantra here at Apex is automate and scale, right? Because this is still, we're still in those relatively early stages of figuring out, hey, what, it was born in New Mexico, it grew up in Colorado, now we're replicating it. And there's a saying in our world that I used to hate, but now I know it's true, that if you've seen one school-based health center, you've seen one school-based health center. And I think the same is true at a state network. You know, there's always that differences in how they fund and what they need. And so yes, hopefully we'll, if you have any contacts in Michigan, we're happy to talk. And that's usually how it starts, right? Like I said, is you know, a conversation. A lot of times based on seeing people at SBHA, then leads to other conversations, and sometimes it takes years. You know, we talked to New York for a year before we got started.
And then Priscilla said, will we have access to survey results in real time as well?
Yes. Now the survey results, so anything, whether it's just health or survey, any of that second use case, yeah, you have access to that as you need it through the platform.
Super. There's a long question from Melanie in Connecticut about meeting with them to see what options there are.
Yeah, so that last screen was my email, but definitely, like I said, it usually starts with a conversation of understanding your context, where you're at. You know, funding always is an issue. Technology usually is, or you know, all the questions you're asking now, we kind of take them one by one and figure out what it looks like to get started. And those are the conversations we're having in some other states. So the very bottom one, Lisa, is that cost analysis something that can be, oh, you're talking about the ROI report, the study on the community school? Yes. As a matter of fact, I'll put it in. Did anyone catch the QR code? I could send it to Tammy.
Yeah,
as well.
Just go ahead and send it. We'll package it with the presentation and your PowerPoint. That'd be great.
Yeah, and if you're at all connected, I mean, I think for me that the community school movement and the school-based health center movement are kind of coming together, and I really like the synergy, and I think there's a data synergy in there as well. But yeah, we can make that ROI study available.
I'm going to put the contact information up really quick again.
Yeah.
There
and
you go.
I can also, if you save that QR code or that link, I can also put it in that drive.
So you should be able to grab it from the slides.
Let's see, what questions is Melanie? Have we gotten your question from Connecticut?
Yes. Starting with the question, meeting with people to see where it goes.
I'm not sure, Melanie, if I understand the question exactly, but if we're saying, I see the all caps, because I think in New Mexico we have the same issue, and we actually do get data from some of the non-state funded sites. I think the stadium gives them a little bit of a carrot around some funding to provide us that. In Colorado, we've been working with the Colorado Association of School-Based Health Center to see if we can bring in non-state funded sites into the data hub. So the goal really is all school-based health centers, not just those that are funded by the state, but sometimes the funding is where, you know, it starts with that accountability and compliance model, and they're the payers of it. We're having similar conversations in Massachusetts, because I think it sounds like that is common in states, is some are state funded and there's others. And if you're at the alliance level, or if you're at the movement level, you want all the data, and I want all the data too. So
great questions, you guys. Yeah, and Jenny put the contact information in the chat.
Yeah, thanks for a lively discussion. I think it's as lively as it can be, you know, in this format. But
oh, we have another question. What does the use of Just Health look like at the patient level? Does an interface with the EMRs?
yes. So it still is designed to be on an iPad, even though it's technically cross-platform. But I think the workflow is that it precedes the first visit. So that's that universal nature. And then it's comprehensive. So the patient actually completes it themselves. The provider, the clinic front desk, however you check people in, will get it started. And then the patient goes through and answers all the questions. And then that generates the alert report instantly for the provider. That wasn't part of the demonstration, but it also is now telehealth friendly, that you could send a link out and the patient can complete it on their personal device, and then it still works the same, right? That they'll do it on their phone, and then the data goes back and syncs, and you get the alert report. Oh, and the interface with the EMR. That is another sort of coming soon and work in progress. What we have done up in Colorado is we packaged the PHQ-9 and the GAD-7, and we're able to transmit that back to their EHR, and they use a Prima, and that was our first proof of concept. But here's the challenge of it, because that's one of the more common questions. You guys are hitting all the big questions. There has to be a place for it to go, right? And a lot of times in your EMR, there is not necessarily a place for every question, every answer, which is why we sort of, it's becoming more common to see things like PHQ-9, GAD-7 in the EMR. And then sometimes it's not every question, every answer, it's a score, or sometimes it's a check off that you did a depression screen. So we really have to map where data is coming and going, but we have the ability to transmit data for our part. But then there has to be some way to catch it and ingest it on the EMR part. And sometimes that is costly, and other times, and one of the reasons it's costly is sometimes you have to create the place for the data to go. So that's part of those conversations around what your needs are and how we can meet them. But we do have the capability to transmit data securely using HL7 protocols, and so the capabilities there. We just got to make it work for you. Does that help, Ashley? Oh, and then there was a second part of the question, is we do have a few sites that are using Just Health that are not part of the data hub. And one of the things that we realize, and one of our learnings is that we appreciate the carrot and the stick of it, is like, in New Mexico and Colorado, where we got started, it was required, state funding was there, you had to agree to do it. And so we had pretty good uptake. And I think some of the other sites that want to use it sort of a la carte, then it really depends on them and their motivations to use it or not. And so, and then it's if it's just health and not sort of pulling together those other things. So it's possible. And that is a rare occasion where sites would pay on their own just to use Just Health, but it's not really where we want to go with the data hub, right? We feel like there's a higher level that we shoot for. But sometimes that's a place to start.
Don't see any more questions. Anyone? For the good of the order. Carlos, I appreciate you coming on today. This is incredible stuff. I can remember when I joined the field in 1993, we kept talking about data, and we had school-based health centers that weren't even, coding and billing. And so we've come a long way, and it's very important data. It tells your story. It's great for funders. It's great for sponsors and school partners, et cetera, et cetera. So I'm just very excited to see where this goes and see the uptake of more states doing this. And I appreciate you and your team greatly for the work that you do. And I'm so glad you came to that conference in LA and you got excited about school-based back in whenever it was, 97 or
Yes.
98, whenever it was. So
I didn't have a single gray hair. I was in my 20s.
I know.
So yeah, it's been a journey.
All right. Well, thank you all for coming this morning. Please reach out to Carlos if you have any more questions, and get a little chance to do a little bit of bio break or a stretch before we hit our next opening session. So I appreciate you all. And thank you again, Carlos.
You bet. Take care.
Bye.
Everyone.